Welcome back to the Band-Aid Man OC, your source for all things sports med, EMR, and EMT. Gosh, I'm never going to get the rhythm of that down. My name's Eric Johnson, aka the Band-Aid Man himself, and we're here to go over Chapter 5, our Introduction to Medical Terminology. Now, again, we're going to be going through the textbook from Limmer and O'Keefe. This is Emergency Care, 13th edition. And again, this is the 5th chapter. So if you're one of my students and you're following along, be sure to download that PowerPoint off our Canvas classroom and use that as your notes. If you are not one of my students, feel free to go ahead and take notes, comment down below, and feel free to shoot me a message if you have any questions, comments, concerns, thoughts, or ideas. Now, as we're going through all of this, the material that we're going over today is a broad, more umbrella statement of what medical terminology actually is. Medical terminology can be distilled into a short PowerPoint like what we're doing today, but really it's a very broad term subject. As someone that has gone through a medical terminology class at my local community college, I can tell you that it's quite a deep dive when you spend 18 weeks learning about it. So please understand that this is a very distilled, a very Cliff Notes version of medical terminology, and obviously this is going to be more specific to EMS, Emergency Medical Services. So if you're watching this video hoping to get more about medical terminology because you're in your doctorate program, you're a pre-med student, this may not be quite enough for your purposes. But if you're going to be an EMT, you're going to work out in the field with us, this might just be all that you need. Without much further ado, let's get started. Now, today we're going to talk about two major topics. Number one, medical terminology and everything that encompasses. And then we're going to dive into the anatomic terms, specifically the way that we are going to relate to our patients and their injuries, their illnesses, their complaints, and the way that we're going to discuss all of this with other medical professionals. So we can get started on the right foot, we're going to start by breaking down medical terminology. Now, the majority of medical terminology makes sense to us English speakers because it is derived from the same bits and pieces of which make up our language that we speak. These are going to be mostly Latin terms. Some of the terms come from Greek, but really these are going to be words that we're very familiar with. For other non-English speakers, this may not be as easy of a transition, but don't worry. Just because this isn't going to necessarily naturally translate into your given language, it'll be a lot easier for you to do. And if it makes you feel any better, as Americans, we're going to really struggle with the conversions because we don't use the metric system. So whereas your language may not actually pair up very well with this, we're still struggling with trying to figure out how to count. So, potato, potato. Anyway. The components of medical terms can be broken down into a couple different broad subject heads. First, we have compounds. These are going to be words that are made up of two or other small words like smallpox, hematoma. Then we have words that are made from parts, like words that have a root, a prefix, and a suffix. Now, a root word would be, again, getting back to our Latin roots, like therm. Therm means heat. When we combine therm with the letter O and meter, we come up with thermometer. Thermometer is a way to measure heat. It is a tool in which we measure heat. Prefixes and suffixes can change other root words by adding a prefix or a suffix and allowing us to express a different garden variety term. So when we look at words like dyspnea or tachypnea, we are adding the word dys, dis, which is the prefix, which in this case means slow. And on the other end of things, we have tachy, which in this term means fast. These words that you see under the prefixes bullet point mean slow breathing and fast breathing. If you look at that core word, the pnea, that very closely resembles pneum or pneumo. Pneum and pneumo really relate almost exclusively back to the pulmonary tract and specifically our lung set. If you'll think about the word or term pneumonia, pneumonia refers to fluid on the lungs. Fluid on the lungs, pneumonia. If you look at this with dyspnea, it's a little bit different. You don't have the PNEU, you have PNEA. Dis, in this sense, means slow. Tachy, in this sense, means fast. On the other end of things, we'll have suffixes, which are going to be short phrases or short words that will end the word and will change their meaning. Arth is almost always going to refer to our joints, whereas in the other word, hemo or hema will refer to our blood. So arthritis means that there is an illness or disorder related to the joints. Hemophiliac, or the IAC added to this, means that there is a disorder or disease related to the blood. Now, as we break these down, it may not be as straightforward to a non-trained individual, someone that doesn't have any kind of experience in medicine, but a lot of these terms are ones that we hear on a regular basis. Most people would be hard-pressed to say, oh gosh, I've never heard of arthritis. But on the other side of things, most people have never heard of dyspnea or tachypnea, because you've never had to say that person is breathing too fast or too slow. And if you had, you might have used a different term. And most people say that someone's breathing too fast. We've heard of this being called hyperventilation. While hyperventilation is technically correct, it is not medically accurate, because hyperventilation means that air is moving very quickly in and out of the airway. It has nothing to do with the patient's ability or inability to both bring air in and out and have exchanges of gases, which is really the difference between ventilation and respiration. But I don't want to get too far into it. We'll talk about that more in Chapter 6. So a more medically relevant term in this case would be tachypnea. Now, there's a lot of folks out there that also will say things like dyspnea or dyspnea. I say dyspnea because it's easier for me. It is kind of a, just a potato kind of situation, meaning that a bit different pronunciation may or may not be excusable. So it is within your best interest to use the tools at your disposal. I highly recommend Googling these terms and trying to find out how to pronounce them before you say them. Because, gosh, you don't want to be that person that's totally mispronouncing it and saying dyspnea. The patient is dyspneic. The patient is what? You mean they are dyspneic, which is also a bit of a personal flush on the way that I like to say it. So, again, understand that the pronunciation may not be precisely what you expected. So take a little bit of time, do the due diligence, and really make yourself look as smart as possible by saying these things. Now, if we look at word components, we are taking many words, prefixes, suffixes, and the root word. So let's look at an easy one. If we wanted to say that someone's heart rate was fast, or really, if we wanted to refer to anything related to the heart, we would use the root term cardio, or in this case, cardia. If we wanted to say that the heart rate was too fast, we would say tachycardia or tachy, fast. Tachycardia means that the heart rate is faster than what we would expect or believe to be acceptable as the human or as a patient is supposed to be at. So if they're an adult, their heart rate is above 100 beats per minute, we would say that they are tachycardic. Moving into a different example, we have, again, the root being thorax and the prefix being hemo, meaning that there's blood in the chest. So let's break that down. Hemo means blood, thorax means chest. Thorax means chest, excuse me. Hemothorax is any time that we have blood in the chest cavity. If we wanted to, let's say, refer to air being in the thoracic cavity, we would change out hemo with pneumo. Wow, my voice really cracked there. I promise I'm not 14. I'm an adult. If we change hemo out with pneumo, then we have a pneumothorax, meaning that there is air in the chest cavity. And if you haven't gotten to the point where we start talking about different concepts of trauma and different types of complaints, you're probably thinking, well, come on, Johnson, air in the chest, that's where we want it. Well, not quite. We want air inside of the lungs, And we definitely need blood inside of the body, but when it leaks outside of its vessel, when it leaks outside of the area and where, which it's supposed to be, we have pretty significant issues because we're not allowing the body to do what it needs to do. Now, again, I don't want to get too far into it because I don't want to, ruin the surprise of EMS and ruin the surprise of all the other PowerPoints you're going to be watching this year. But I do want to remind everybody that there is a very specific reason that we have these words. It helps us better explain what we are seeing. If you find yourself in a position where you're trying to explain, hey, this is what's going on, and you just can't remember that word, if you're trying to say, hey, the patient is experiencing a nosebleed, but you can't remember the term for nosebleed, which, hint, hint, is epistaxis, because it doesn't really have that root word. It doesn't have that prefix. It doesn't have anything that we would expect to see for a nosebleed, because you would want to say hemonasalia or nasohemotoma, something of that nature. That's not going to be the case. If you can't remember what the exact term is, don't write it down and don't try to say it out loud. It's perfectly acceptable for you to say, the patient has a nosebleed. And then you'll probably have some nerd like me go, you mean epistaxis. But, really that's just a teacher in me. I'm just trying to find ways to teach everybody a little bit at a time. For our last example of word components, we have cardiologist. And if we break it down, we have our root word, cardio. That's going to be who we are dealing with. Then we have the suffix ology, and then another suffix, ist. Cardiologist is someone that specializes in the study of the heart. It's as simple as that. Now, I don't want to get too far into it because we could sit around and we could look at words all day. But if you look at all of these words, you can start to look for the root, then the prefix, suffix, so on, and figure out exactly what you're talking about. At the very least, based on inference, and that's our ability to determine what something is based off of simple clues, we can start to determine what we're dealing with. If we see a term like cardio, we know that that is going to be dealing with the heart. If we see the suffix logy or ology, we know that we're discussing the study of something. And if we see ist or ist, we can already determine that this is a specialist or someone that specializes in this area. Now, we have different types of acronyms, mnemonic devices, abbreviations that help us do our job. So I wanted to break all three of those down. First and foremost, we have acronyms. It's an abbreviation that's made up of different initials, but it can be pronounced as a word. For example, CPAP, CPAP. CPAP is known as continuous positive airway pressure, and what it is a device that does just that. It continuously provides positive pressure to the airway. It pushes air directly into the oropharynx or nasopharynx, down into the lower airway and into the lungs. This device is pretty familiar to people because it's not something that we only use in EMS. It's something that we also see in regular civilian use. CPAP is known almost ubiquitously as being at-home treatment for obstructive sleep apnea. So these types of words, these acronyms that will mean one thing, but they can be said as a word, are littered throughout EMS. But as a brief example, CPAP is a perfect way to show this. An abbreviation is when we use letters or symbols or numbers in place of words or phrases, such as DNR. This is different than an acronym because we don't say, the patient has a DNR. That doesn't make any sense. DNR stands for do not resuscitate. But it's easier for me to say, hey, the patient has a DNR, stop CPR, instead of saying, the patient has a do not resuscitate order, stop cardiopulmonary resuscitation. Everything that we do really has time being the essence. We want to be efficient, we want to be quick, and we want to be precise. So that's what we have, these acronyms and abbreviations. Finally, we have mnemonic devices. In EMS and really in medicine in general, we have a lot of complex thoughts, terms, and ideas that we need to be able to recall at a moment's notice. A perfect example of this would be OPQRST. OPQRST is a mnemonic device, which is kind of like the word anemone. Got a whole lot of letters that don't really do much, but really, these mnemonic devices act as a memory aid. OPQRST is used specifically to gauge the severity, really, and a lot of other components of someone's complaint. A lot of folks in EMS think that OPQRST can only be used for injuries, but that's actually incorrect. We can use it for illness as well. So let's break this down. OPQRST stands for onset, meaning did this occur suddenly? Was this an acute onset? Or was this a gradual or insidious onset where it took time to become more of an issue? Provocation, or what provokes it, what makes this better, what makes it worse, and specifically what makes it worse. Quality, tell us about the kind of pain or discomfort you're having. Is it sharp? Is it dull? Does it feel like stabbing? Does it feel like it's burning? Radiation, this refers specifically to pain that starts at one area and then ends up in another. That can mean one of two things. That pain is now affecting other areas because of some type of spread of materials, possibly swelling or something of that nature. Or it can be because we are touching on a very specific nerve, an area that innervates a specific component of the body hurts elsewhere. This is where we see things like patients complaining of left-sided arm pain during a cardiac event because the heart is innervated with the phrenic nerve, which also runs down the arm, specifically the left arm. Then we have severity. Typically, we use the scale of 1 to 10, 1 being no pain, 10 being the worst pain you've ever experienced. There are other ways that we can refer to severity using smiley or frowny faces if they're kids, but sometimes you're going to need to be a bit more creative. A lot of patients will say things that are ridiculous, like, "Oh, the pain's 12 out of 10." Well, in addition to being completely unable to do math or understand numbers and scales, you are also going completely off the scale. Patients will do this because they are trying to describe that the pain for them is very unbearable. But in my own professional experience, someone that's truly having 10 out of 10 pain will only be able to get out moans or cries or whimpers. It's very rare that they're having true 10 out of 10 pain and they can say, yeah, it's about a 10 out of 10. Usually that's it's not quite right. But of course, pain is subjective, so we don't want to do anything more than report our findings based on what our patient states. And then finally, we have time. Now, a lot of new EMTs get this messed up, so I want to be clear here. Onset and time do refer to passage of time, but onset really is, did this happen suddenly? Was this chest pain that you're experiencing? Did this happen all of a sudden, or has it been getting gradually worse over the last few days? Time is specifically how long has this been going on. If it has been going on for the past few days, we want to reflect this has been going on for approximately 3 days. If we can get even more granular, we'd like to say this has been going on for approximately 72 hours. If it is something that's more acute, something that happened in a more rapid fashion, we may need to say that it happened in a shorter period of time, minutes, maybe even seconds. But it's all relative, okay? Now, there are plenty of mnemonic devices. There are plenty of acronyms. And you are going to hear people call mnemonic devices acronyms and acronyms mnemonic devices. They are a bit interchangeable, but I wanted to bring them up because it is a huge part of what we do in EMS is use these different devices. Some other examples of this are my least favorite acronym, DCAT BTLS, which is used to basically be a vocabulary exercise when it comes down to trauma. Then there are specific mnemonic devices that we use for specific tools, like our Kendrick extrication device or our seated extrication tool. And the mnemonic device is in relation to the order in which we put on straps. The mnemonic device there is "My baby looks hot tonight," which basically stands for, or it does stand for, middle, bottom, legs, head, torso. My baby looks hot tonight. All right, moving forward. When we want to refer to these different medical terms that we've used, That's pretty much going to be when we're talking to other medical professionals, especially when we're doing some type of a radio report, but also when we're conducting our handover report. It's appropriate to use these medical terms in our documentation. And of course, it's appropriate for us to use these anytime that we're in a classroom or an educational setting. However, we don't want to use these when we are talking to patients or family members. If there's ever an opportunity for you to erase any kind of patient rapport, bedside manner, really the relationship that you're building with your patient, it's in these situations. When you start using complex terms, when you start saying things like dyspnea or tachycardia or hypertrophy or something of that nature, you're going to confuse the patient, and you can even make them feel less comfortable with your ability to do the job. It's not to say that you don't sound smart, but as humans, when we hear things that we don't understand, and when we hear these complex terms that don't have any kind of real relationship to the way that we understand things, we tend to not only tune them out, but we tend to fill in the blanks with our own knowledge. And if you don't know what someone's talking about, especially if you're having a medical emergency, it can make the situation even worse. Also, you may find yourself, especially in the beginning of your career, that you use the wrong term or that you misrepresent what you're trying to say because you're not as familiar with the word. So I'm going to give all of you a piece of advice that I think is very pertinent. If you don't know the word, and if you are not 110% certain that you know what you're talking about, just go back to the way that you know how to say it. Now, this should be used with, some caution. We definitely don't want to have ourselves a moment where we forget the name for the region of the stomach. We call that the abdomen. But we don't want to have one of those moments where we regress and we say, yep, the patient's complaining of 8 out of 10 tummy pain, because then that kind of removes our professionalism. It takes away from who we actually are as professionals. So there is a line, and you need to be very cautious about crossing that line. But if you're not sure, keep it simple, and don't try to overstep or outstrip your own ability to state what's actually going on. Anatomic terms are going to help us, again, better reflect what we're looking at. It's going to help us be more specific as to the site or as to the location of specific injuries. And as I said at the top of the video, this is not going to be an in-depth dive into anatomic terms and into medical terminology. If you really want to be in that space, you should take a standalone course because it's a dense course, and we simply don't have the time to go through all of that. As we're dealing with anatomic terms, it's important to define these actual pieces of terminology. Anatomy is the study of body structures. Body structures. I don't know, sorry, I'm having a moment. Anatomy is the study of body structures, whereas physiology is the study of body function. And if we go a step further and get into pathophysiology, that is disorders of body functions. But I don't want to overstep. Now, when we're referring to our patient, we need to refer to them in the position in which we find them. Ideally, the anatomic position would be how we're referring to them, but as we work in EMS, we understand that we're rarely going to find our patient in the anatomic position. Now, the anatomic position has our patient facing forward. Their hands are at their sides, and their palms are facing up. It's not a very natural position, but this is the anatomic position. Also, before we go any further, it's important to understand and to really lock in. When we say that our patient is having pain on their left side, we literally mean on their left side. As you're looking at the patient in this anatomic position, their left hand is going to be on your right side, correct? Of course. Remember, it's always to the orientation of the patient. Their left hand is their left side. Their right hand is their right side. So on and so forth. So now that we've discovered all of that fun stuff, we need to start breaking down the body into digestible planes. Now, the very first plane that we talk about is the midline. Now, in my classroom, I say I want you to think of these as invisible panes of glass that we're shoving into our patient. And I'll let you know right now that if you shove panes of glass into people, they're going to die. So these are going to be imaginary panes of glass. The first imaginary pane of glass that we're going to shove into our patient is on the midline. This divides the patient directly down the center, and it gives us the best representation of the patient's left and the patient's right side. This is going to be where we start to use terms like medial and lateral. Anything closer to that center point is referred to as medial. Anything further from that is going to be lateral. Now, these are relative terms. So it's up to you, the provider, to decide if you should use medial or lateral. Medial being the term that you would want to say, hey, anatomically, this really is closer to that center point. So a good example of that would be the sternum is medial to the pectoral muscle, meaning that the sternum is closest to the midline as it refers to the pectoral muscle. Lateral would be further away from that midline. So the pectoral muscle is lateral to the sternum. Make sense? Super easy. Moving forward, take another pane of glass. Actually, you know what? You've been good. Take 2 panes of glass. Now, take those 2 panes of glass, find the collarbone of your patient, and split it in half. So take those panes of glass and shove them directly in between those 2 collarbones or clavicles. The midclavicular line is important when it comes to placement of certain things like the pads for a 12 lead, the electrodes and the terminals for the 12 lead. It can also be important to further bisect the chest and all of its components. So anatomically, normally this line will run from the middle of the clavicle through most people's nipple line and then goes all the way down about to the belt line. We don't really use the midclavicular line for anything off of the chest and abdomen area or the trunk, and we're likely only going to use that for complaints as it relates to the chest and abdomen, and really just to the thoracic cavity on the chest. Then we have one more line to add in, our mid-axillary line. Take another one of those panes of glass. You're going to have your patient put their arms straight up. The mid-axillary line runs directly through the middle of the armpit. Shove that pane of glass in, and that's where we are able to start to understand the front versus the back of our patient. Now, we've been using a lot of these invisible panes of glass to divide people or our patient into front and back, left and right, and then further divide into left and right with the midclavicular line. If we have somebody complaining of something that affects both left and right, both front and back, we would say that it's bilateral, or if it's only on one side, we would say that it's unilateral. A great example would be one that we get a little more often than other kinds of injuries, where we have someone that falls and breaks their fall with their hands or with their arms. A very common fracture is the radius and ulna of the lower upper extremity, so the forearm area. And if we have someone that falls with enough force or from a great enough height, it's very likely that they will break both sides. To refer to that, we would say that they have bilateral radial and ulnar fractures. If it wasn't on both sides, let's say that only one arm was fractured, but both sides hurt, we would say the patient presents with a unilateral radial ulnar fracture and bilateral pain. Alrighty, moving forward. Our very last directional term is going to be the transverse plane or the axial plane. It's used to describe the different horizontal aspects of the body, and it is a bit different than our other directional terms because it can move up and down. So as it's needed, we can use this on the extremities, we can use this on the thoracic cavity, we can use this on the abdominal cavity, but typically where it lies is directly in the center of the umbilicus or the navel, your belly button. So understand that this transverse plane is a bit different than the other lines because it isn't really relegated by different parts of human anatomy. So it doesn't need to be in the center of the body at the midline. It doesn't need to be in the middle of the collarbone, the clavicle, like our midclavicular line. And it doesn't need to be in the middle of the armpit or the mid-axillary line. It does have a bit more flexibility. Now, while we're talking about the transverse plane, we're able to start using other terms like superior and inferior. We've also got other terms that we will use based on our understanding and our usage of the mid-axillary plane, like anterior and posterior. So let's talk about front and back. Anterior, or front, can also be referred to as ventral. This is typically reserved more for animals than it is for humans, but it could be used depending on the actual application. This is usually reserved for different aspects of injuries that involve both internal and external aspects, but more often than not, we'll use anterior to refer to the front and posterior to refer to the back. Superior and inferior refers to the top and bottom of that transverse plane. And really, it means that it's above or below something. So you need to find an anchor point. You need to find something that is not going to move to say that something is superior or higher than, or inferior or lower than. When we're using other directional terms, it may refer to its distance to a specific locked-in anatomic position, like the torso, or to a specific aspect, like the patella, the kneecap. Proximal and distal can be used to show that it's both further or closer to the torso, or you could use proximal and distal related to another term. The wrist is distal to the elbow, but it's proximal to the phalanges, to the fingers. Does that make sense? Shoot, you can't answer. I guess that's going to have to make sense. We also have other points of reference, like palmar and plantar. Palmar refers to the palm of the hand. The palm of the hand being an area that we would want to definitely be able to refer to because it is the softest, most often involved component of the hand when it comes to injuries. But really, it's different than the top of the hand or the dorsal aspect of the hand. The plantar, or bottom of the foot, again, is going to be softer and more easily injured than the top of the foot, or the dorsal aspect of the foot. So as you can see, we do have different ways of referring to things, but it's not as black and white as you would say, top is dorsal, bottom is ventral. You could refer to the palm as the ventral aspect of the hand, but you'd probably confuse some people. So palmar and plantar are very site-specific. They are going to refer to individually the palm of the hand, palmar, and plantar, the base or palm of the foot. Here's a quick picture to help you understand different aspects of the directional terms, the different extremities, the torso, the head, lower and upper extremities, and obviously different anatomic structures therein. I'll give you some opportunity to pause, take a look at this. If you're in my class, you can obviously look at this both in your book and in your YouTube video, as well as on your PowerPoint presentation that you can download and manipulate as you need. Here's a quick picture to help you better understand those directional terms as we've discussed earlier. Again, if you want to go ahead and pause, take a screenshot, or reach out to me, I'd be happy to share this with you. And these directional terms are not going to be much different in any other diagrams, so feel free to use diagrams from your own book if you're not in my class, or directly off of Google or Bing or any other search. But really, these terms are not going to change unless you are in a very specific area of medicine where the directional terms will be better suited for what you're dealing with. And that would be more specific to things like radiology, where you're going to be dealing with the bones and internal aspects of the body as well as their relationship to the outside body. But because we don't really deal with the internal aspects very often, we're only basing that off of anatomic knowledge. We are not going to be dealing with actual imaging. Finally, here's a picture of those directional terms as we discussed earlier. You can see the frontal plane runs along the mid-axillary aspect. The mid-axillary line, that frontal plane, divides your patient into the front and back, or anterior and posterior aspects. The sagittal plane, or median plane, is the one that runs along the midline, the middle. And then finally, we have the transverse or axial plane. That's the horizontal plane. And as I said before, it depends on what you're looking at and what area of the body you're actually inspecting. Typically, the transverse plane will lie directly in the center of the abdomen at the navel. As we're dealing with the navel and we're dealing with different aspects of the abdomen, it's important to understand that we have different areas and we have different wording to refer to those different areas. So we have what are known as abdominal quadrants. Using that concept of the midline and the transverse plane, we are able to divide the abdomen into 4 equal quadrants at the navel or the umbilicus. We have the right and left and upper and lower areas. So the upper right area, where the majority of our liver is located, as well as our gallbladder and parts of our stomach, will have the right upper quadrant. Same with the left, upper, and lower. Now, some areas of medicine actually have this divided into 6 parts or 8 parts, but those are going to be more specific to internal medicine as well as gastroenterology and different aspects of the organs therein. For us in EMS, we need to keep things to a bit more of a simple point of view, so we keep it into 4 equal quadrants. As you can see here, divided on this gentleman's abdomen, we have the right upper, right lower, and left lower quadrants. These can be referred to in your paperwork as RUQ, or right upper quadrant, and on the opposite side, left lower quadrant, or LLQ. But I wouldn't really advise that you say things like the RUQ. See, that doesn't even flow. It's hard to say. The RUQ is where the patient's having pain. And this diagram is going to show the majority of patients and the way that their organs lie. Obviously, humans are all different. You may find that the organs are a bit differently positioned, but really it's not going to deviate too far from this unless your patient has a genetic defect or a genetic disposition where their organs have been swapped. And we'll talk about that later on in further chapters down the line, specifically in cardiac. Now, we've talked about all the different planes of the body. We've talked about the difference between anatomy and physiology. We've even helped you break down medical terms. The final aspect that we need to talk about are positional terms, how your patient is positioned. First and foremost, we have supine. This is going to be the closest to the anatomic position. Remember, that's with the patient facing forward with their hands at their sides and the palms facing forward. Supine is when your patient is laying on their back. This is a position that's not very comfortable for most patients. So if they're lying supine, they are most likely unconscious, unresponsive, in serious pain, are concerned about their injury, or have been laid that way by bystanders, family members, or other responders. On the other side, flipped directly over, we have prone, or the patient lying on their front side. Prone is not where we want to have our patients. In addition to being difficult to observe their airway as well as chest rise and fall with their chest going up and down as they breathe in and out, it can also put additional pressure on their chest, which can put additional pressure on the lungs and the heart. So if we find our patient in the prone position, we want to very rapidly transfer them over to supine, or if they're conscious and complaining of pain, nauseousness, vomiting, or are pregnant, we'll put them in the recovery position. The recovery position has our patient laying on their side, and specifically, it's going to be on their left side. We've discussed this in a previous chapter. We called it the left lateral recumbent position, or left lateral. And honestly, it's the best position that we have for patients that are at risk for aspiration from vomitus, sputum, or any other bodily fluids that they may have that are collecting in their mouth. This is not going to be ideal for patients that are victims of traumatic injuries because we can't effectively control the spinal column as well as the cervical spine. So these positional terms, they all sound good on paper, but what do they look like? Don't worry, nobody, we're going to show you. This patient is in the supine position. You'll note that the patient has their palms face down, so they are not in the anatomic position. But this is supine. This patient is in the prone position. They are laying on their front. This patient obviously was placed in that position. This person or actress is in that position because she's been photographed there. but our patients that are truly in the prone position may not be nearly as collectively placed. So if you notice that they're laying on their front, try to get them off of their front as quickly as possible. And then we have our patient in the recovery or left lateral position. The recovery position can be on the left or right, but in this picture, this is the technically the right position, but it's not going to be the position our patient lies in. The reason? Well, it's not going to be very easy for the patient to maintain that position laying on their side like that. So typically, one of the legs, typically the right leg, is arched forward to act as front support, and then one arm is behind to act as back support. We also have the Fowler's and semi-Fowler's position. What you see here is known as semi-Fowler's. The patient is at a slight or nearly complete incline, and the patient has their legs flat. We also have Fowler's, where the patient is seated in an upright position. Now, regionally, they're all called different things, but typically where I work, we call that seated or upright, with semi-Fowler's being at a semi-reclined position or semi-seated position. Now, this is going to end being our very last slide, but I do want to remind you that there are some fantastic videos out there on how to position your patient. I'll be placing some more videos up in this channel on how to appropriately place your patient or position your patient based on their specific complaint. And of course, we're going to be talking about different scenario-based positioning when we find our patient and how we would like to have them positioned. But again, this is the last slide. Thank you very much for tuning in. I appreciate all the time. Be sure to hit that subscribe button. If you like this video, give it a thumbs up. And if you have any questions, comments, concerns, thoughts, or ideas, please be sure to put them down below in the comments. I'm your man, Eric Johnson, aka the Band-Aid Man OZ, signing out. We'll see you next time. Bye-bye.